ultrasound training, I always break it down into 3 different stages. First, we need to position the patient and actually landmark them. Then we need to actually acquire the image, and then finally analyze that image. Fairly straightforward. The first thing we need to consider is actually the angle of the bed. So I'm not too familiar with using these, but I'm assuming most people will be in some degree of bed elevation. So you want to try and minimize that for the analysis if you can. But whatever you do is just record it and make sure you keep that same bed angle across all assessments, because it can affect your landmarking and everything. As well as where their hips are placed, because if someone's like their hips are further down, it's going to have less of an impact on the angle relative to their hip flexion. So just try and sort of standardize that. Make a note if you notice that they are further down. So for the next thing you consider is the knee angle. So we want to have it fully extended and relaxed. If it is uncomfortable for them, you can place a small towel underneath, but try not to have it too flexed. So full extension is ideal, as well as nice and relaxed musculature. If they're cooperative and conscious, that is, you can ask them to try and relax. And then the last thing that's probably the most important aspect is the lower leg rotation. So oftentimes when people are relaxed, that lower leg tends to flop out to the side like that, and that's going to change both our landmarking and how that gravity affects the muscle. So we really want to try and bring that back into neutral rotation. So make sure the knee is facing straight up. You can, I think I have a strap that I use. I don't know where it is actually, but you can also use like rolled up towels to assist that, in which you can sort of bring them into that position and put towels on either side of the leg to really try and maintain that position. My strap is in here. So we have this strap that I use, but just to sort of make sure that their legs aren't rolling out. I don't think it's as feasible in the ICU, so towels are probably your better option. So that's basically patient positioning. We just basically want to standardize it to make sure they're always getting back to that same position. So there's 2 landmarks we're using, the patella and the anterior superior iliac spine. So for the patella, we want to mark the superior border, but really the superior border is pretty large, so we want to really mark the middle of the superior border. So when I'm palpating, I'll sort of just walk up the patella until it just crosses over that crest. You'll feel it fall down, and so we want to mark it on the skin. But make sure you're not pulling the skin as you mark it, because it's going to adjust where the landmark actually falls. So I tend to just walk up, and then I'll do a horizontal cross. Skin marker. A horizontal cross, and then I also sort of pinch the lateral and medial aspects and just sort of eyeball the center. So now I have a specific point that I can always bring my tape measure back to, rather than this really broad horizontal line. For the anterior suprailiac spine, I tend to walk up from the inferior aspect, so I'm actually going to bring you down a little bit just so it's a little easier. And if you have visual access to it, you can also mark it with a pen. If not, you can just palpate it and place your tape measure there. So it's kind of hard to see. So basically I just walk up, and it's usually around like the waistband of most people's pants, but I guess they're be in a hospital gown. But you just sort of walk up until you can feel a bony protuberance. And so we'll place the beginning of the tape measure there. And I measure everything in centimeters, so make sure you really use that same side of the tape measure on both landmarks. So I'll put that exact point right where the anterior suprailiac spine is. And then oftentimes if there's clothing in the way, or if the tape measure gets bunched up, it'll change your measurement. So I always hold it tight here, pull it taut, and come nice and high, straight down onto that landmark. And again, you want to use the same side of the tape measure at that exact point. And so we'll have a distance here of 45.5 centimeters. And so we'll record that. And we're really taking 2/3 of that distance, which is 15 centimeters. So we want to go from 15 centimeters up from the knee and mark it on the thigh. But make sure that you maintain this straight line, right? Because if you go 15 centimeters up to here, that's going to be a different landmark rather than if you go here. So we want to use that exact point, that straight line. Use your tape measure as a line to actually make your measurement. So you can roll up the shorts. And so we'll measure 15 centimeters from there to the anterior superior iliac spine. And so if you have someone to help you, you can have them mark it. It's much easier. But oftentimes if you're alone, I usually walk up the tape measure by just going one finger after the other. And then you can just kind of splay across the landmark that you need. And so then you use that as your horizontal line or your vertical line. And then you can make the exact measurement at the 15 centimeter landmark. So you'll have basically like a T or a cross at the exact point. And throughout this, their legs might tend to flop back out to the side. So just always be conscious of that, especially when you're going to take your image, that you can really bring them back into that neutral rotation. And use that exact same line, right? So you can go from the knee mark, and you can use that as your line, and you can just measure the 10 centimeters landmark. You might as well do it now if you think you'll have to use that landmark if they're a larger patient and you might not have the depth with your ultrasound to actually image the femur. So the new landmark we've added, I call it the architecture landmark. It's super simple to do. You use it for the 2/3 landmark if you have it, and you basically want to just measure 5 centimeters lateral from this measurement. So it's just completely perpendicular to the long axis of the femur, and you do the exact same way in which we'll just measure 5 centimeters laterally with the same sort of landmark. So you should have those 3 landmarks essentially. So that's the all landmarking and patient positioning done. So moving on to image acquisition, we have to actually set up our ultrasound now. So everyone has different ultrasounds. I think quite a few sites have the Sono site, but there might be some GE in there as well, or Mindray, I'm not sure. So these are all very different. So I'm not going to get too much into it, but if you need help setting it up, please contact me and we can go through, because there's various settings that you should really standardize on your ultrasound. Here they always set it to general, and then there's a lot of proprietary imaging software. You should just try and turn those all off, just so it's so they're more comparable to each other. And then we can set up the patient. For here, we'll just do patient 1111, and then also what's the collection date. So here would be baseline, for example. And I'll show you guys all this in the actual one-on-one training. And so now we know that it's set up correctly because the patient ID is up here and it'll be saved on all the images. So next we really have to position ourselves. So really I suggest whatever's comfortable, but I have 2 suggestions. So I guess 3. If you can be seated, it's easier to work with. So I'm trying to grab this chair actually. And so oftentimes when you are using the probe, if you just let the probe sort of just hang out, the cord tends to pull, and it just makes it more challenging to get a correct tilt. So I always put the cord around the back of your neck. It just supports it better, so you're not getting as much pull. And then the second thing, and this is probably the major one, is you have such gross movements with your shoulder and elbow, and we don't really need that to actually manipulate the probe. All the movement you need is right here in the fingertips. So if you guys take a bunch of rolled up towels and you can put it on the bed, you can rest your elbow. Because now look, this is all the movement you're going to need to do your adjustments. And by resting your elbow, it takes out a lot of degrees of freedom, makes it much easier to get a good image. So when we actually go to take the image, we're applying the gel. So everyone's using the linear probe in this case, rather than the curvilinear or phased. So you want to apply it as you're applying toothpaste, but you want a good amount of gel on it. The more always helps. So that amount of gel would probably be adequate for an image. And so you can adjust your depth, usually between 4 and 4.9, somewhere in there is probably adequate for most people, but you can adjust your depth as needed for the image. So feel free to go as much or as little as you need. So when we actually go to hold the probe, all probes have markings on them. This one has this little circle here, and that corresponds to that. There's a little green dot, just so it gives you orientation for the probe. And just wherever you do, just make sure you're consistent in your own site or your own within the same patient. So personally, I always hold that little dot with my thumb, on the thumb side at least. And so we're actually going to take the image. We can rest our elbow. We want to take it in that transverse plane. It looks like this. So this is not a good setup right now. Normally I would have this ultrasound facing me right here, just for simplicity, but just so everyone can see, I'll sort of do this really awkward position. But basically, always have your other hand, your free hand, on the freeze button, because as soon as you get an image you're happy with, you don't want to be searching for that button, right? You want to freeze the image and you're good to go. So on this probe, it's nice, it has these little markings that give you the center of the probe. We want to place that down right on the center of the landmark. So right down here. And we just want to come down into very little compression as possible. So I need a little bit more depth here until I can see the femur. So I'll just freeze to kind of orient everyone quickly. So, okay, just to orient everyone. So the probe is like as if we were imaging it like this. So the skin, we have the bright gray line right there is the skin, subcutaneous fat. Here's the rectus femoris, vastus intermedialis, and then that bright white spot there is the femur. And so basically there's two criteria I have when we're trying to get a good image like this is we want minimal compression and we want a good probe tilt. So for minimal compression, really, this is actually a pretty good image. So you can see there's this black area above the skin, and that's the gel. So there's a thick layer of ultrasound gel between the probe and the actual skin. So there's no contact between those two, so you're not really inducing any sort of tissue depression. As well as if you look at the skin and the muscle, they're nice and concave. They're not flat. So I'll show you what a compressed image looks like. So here, there's no longer that nice layer of gel between the probe, as well as you can see the skin is completely flat. So there's full contact here, and so and now we're depressing the skin, we're depressing the muscle, and this image wouldn't be adequate for analysis anymore, so we'd have to retake it. So for probe tilt, because if we're tilting the probe like this versus like this, we're going to get different thickness values. So we need to make sure we're as perpendicular as possible. You can do it visually, but really the best way, if you look on the screen, you can see the femur down here. And so as I tilt it, it disappears. Like it gets really fuzzy. So as I'm tilting it back, you get that really bright echo. When you have a bright echo, it's completely perpendicular to the bone. And so really you tilt back and forth until you get that bright echo, and you see that, you can then freeze it and do your analysis. So those are really the two main criteria you're looking for. Honestly, the best way to do it is have the gel on the probe and come down at first contact and get a good image. If you come down and you're adjusting it and moving the probe around, you're just pushing the gel out of the way, and it's going to be very difficult to get that minimal compression. So you really need to have fresh gel and just come down and touch it, and with minor movement is where you'll get the best image. And this is really awkward, but if it's over here, it's much easier to sort of make sure you're in the center of the landmark, because oftentimes you might be drifting here. So make sure you're centered, check the image, confirm both, freeze it. And now for this one, we have a bright femur, and we have a nice layer of gel. The skin looks good, so that would be an adequate image for the thickness analysis. So we want to save an image blank right off the bat. Just so for some of the offline measurements like echo intensity, so quality measurements, and then we want to do the analysis and save it. And so we take 2 images at the 2/3 mark or the 10 centimeter that look like this, and you can do your your thickness analysis. And then we're also taking 2 images at the new architecture landmark. So I'll show you what those look like. So for all the 2/3 landmarking, we've been holding it in a transverse position, like this. For the architecture, we actually want to turn the probe 90 degrees and hold it in a longitudinal view. So sometimes this is actually easier without the pad here, but again, still try and rest your elbow. As well as maintain some consistency with the probe orientation. So for this one, we use the exact same principles. Minimal compression is quite challenging for this landmark, so it's less important. Don't be like putting a lot of pressure on the probe, but you probably won't get that nice layer of gel, and the skin doesn't look concave in this view. But anyway, so we put the probe down. What we're looking for is, so I'll orient everyone to the screen. So now we have the skin again, subcutaneous fat. Here is now the vastus lateralis, vastus intermedialis, and then the femur. So what you're looking for here is, again, a nice strong bone echo for that femur. And the new thing that's really important is you can see these striations that come up in these lines. So those are called those are your fascicles. They're bundles of muscle fibers. And so with this type of image, we can calculate the angle at which those fibers are leaving that connective tissue sheath, and that's called your pennation angle, as well as we can calculate how long those fascicles are. So this is all done by offline, so you don't have to worry about it. But that's just 2 things to consider: is can you see the fascicles, and do you have a sharp femur? And this one's very clear in which the femur becomes sharp or not, so I'll show you. Just like very minor tilting, like the femur, it's sharp, and then it basically disappears almost. Like, see, it's just gone, and then it comes back into view. And that's just with very, very minor tilting. So those are the 2 things to try and find. And again, you would take 2 images of this as well, but just save them as blank images. Now for the actual analysis stage. So we have everything set up. So I'll just take a quick image, and then we can kind of walk through the analysis. So for the thickness analysis, there's a caliper tool here, and all ultrasounds have caliper tools, or they should. and it'll set the calipers. For this protocol, you want to start with the center of the rectus femoris, and so you can just sort of visually eyeball it on either side, and you just want to pick the center of it. I saw a lot of people the other day in which they are sort of using their fingers as mini rulers. That's actually a nice idea. Some people, you can see a connective tissue sheath that actually divides the rectus femoris in half, and right here you can see this little connective tissue line that comes up on some people, maybe not on others, probably not so much in the critically ill, but if you do see it, you can maybe try and confirm that you're in the center. So you can set your caliper, and you basically want to go to the top of the fascia, but the lower border of it, that's on the side of the muscle. So, and then you can set it by hitting select, which will change to your other caliper tool. And then you want to come down to the femur and use the shortest distance possible. Again, coming onto the very anterior aspect of the femur. And so this is a very nice one in which you can just sort of scroll across until you see what the distance is, and then you can save that analysis and also record that in your CRF data sheet.